The Bentall procedure is the gold standard surgical intervention for composite replacement of the aortic wall, aortic root, and ascending aorta, coupled with the re-implantation of the coronary arteries into the graft. This procedure is primarily indicated for pathologies that involve both the aortic wall and the ascending aorta, often where wall sparing root replacement is not viable. Common indications include aortic root aneurysms, often associated with connective tissue disorders like Marfan syndrome, Loeys-Dietz syndrome, or Ehlers-Danlos syndrome. Aortic dissection, specifically acute type A dissections that compromise the aortic root and wall commissures. Annulo-aortic ectasia, severe dilation of the proximal aorta and aortic annulus, typically presenting with severe aortic regurgitation. While the original 1968 Bentall procedure involved wrapping the native aorta around the graft, the modern standard is the modified Bentall button technique. The diseased aortic wall and aneurysmal aortic tissue are excised. The left and right coronary ostia are dissected out as distinct buttons of surrounding aortic wall tissue. A composite walled conduit, a synthetic Dacron tube with a pre-sewn prosthetic wall, is sutured to the aortic annulus. Holes are cauterized into the Dacron graft and the coronary buttons are anastomosed directly to the conduit. The distal end of the graft is sutured to the native healthy ascending aorta or arch if required. Wall selection and lifetime management. Selecting the walled conduit is arguably the most critical decision in the preoperative phase. Choosing between a mechanical and a bioprosthetic wall for the composite graft requires a comprehensive lifetime management strategy rather than a simple binary choice based on age. Conduits with mechanical walls offer excellent durability and are typically preferred for younger patients, often the demographic with heritable aortopathies, but require lifelong stringent anticoagulation with warfarin and carry a persistent risk of bleeding and thromboembolism. Conduits with biological walls eliminate the need for lifelong anticoagulation, but the risk of structural wall deterioration is inevitable. Reintervention on a failing bioprosthetic Bentall graft is technically demanding, though valve-in-valve TAVR within a surgical conduit is increasingly becoming a viable part of the long-term management algorithm for these patients.